Yeah. So Cameron wanted.
Okay.
Ready?
Galen.
Well, good morning, everybody. Sorry for being, I guess we're about 13 minutes late. I think we had some technical difficulties, and but we'll still try to stay on time today. So I would like to just remind everybody to take a look at our mission, which is at the bottom of the page, and I will read it. To provide public health services and foster collaboration actions that empower our community to improve its health and safety. And our vision, to optimize the health and wellness of individuals and families through innovative practices. And I think it's just always important to set the stage of a meeting like this by sharing. So again, it's good to be with all of you today. So we have the first action item, and that's the approval of the September 6th.
So moved.
Second. All in favor, please.
Aye.
Aye. Okay, that's unanimous. Thank you very much. And then it's my pleasure to introduce our administrator, Christina.
Good morning, everybody.
Good morning.
Great.
So in your packet, you should have a program report that provides some highlights from each of our respective divisions for the past quarter. I'm going to talk through this morning one aspect of our work that's developed this past quarter, and that's the Overdose Data to Action local grant. And I want to talk about that in the context of some of the 2023 priorities that we outlined at the beginning of the calendar year. So you remember at the beginning of the year, we identified a few priorities that the Office of Public Health was working towards from an overarching perspective, from the systems and infrastructure perspective, conducting workforce assessments, reviewing and strengthening our public health communications, stakeholder participation practices, reviewing and strengthening diversity, equity, and inclusion in our policies and practices, reviewing and updating training professional development across all of our program areas, reviewing and updating our standard operating procedures, and expanding the use of data to focus on inequities, risk factors, and integrating that more fully into all of our work across the Office of Public Health. So we can ask you to advance to the next one. So a little bit farther down in the agenda, you'll see that there's a section on revisiting 2023 OPH priorities. Troy is going to talk through these first few, the workforce assessment, public health communication, stakeholder participation, and reviewing and strengthening diversity, equity, and inclusion in our policies and practices. Next one. Jay will talk through a little bit about reviewing and updating professional development and training across all of our areas, and reviewing and updating standard operating procedures, and provide just a brief update on some of the division-specific priorities that we identified at the beginning of the year. And for you to mind advancing, I'll talk just for a moment now about expanding the use of data to focus on inequities and risk factors in our work. I'll ask you to go to the next one. You'll remember at the beginning of the year, and probably also in September, I talked about a few updates to our staffing structure, the overarching org structure for the Office of Public Health. We've added health promotion. We're squarely back into the Office of Public Health. We've added a group policy coordinator. We'll talk a little bit about, in addition to our staff for public health communications, we'll also be adding a director for health equity in the coming year, probably in the first quarter. We're looking at more of an epidemiology or data focus on this kind of work that will allow us to, again, more squarely and more systematically integrate assessment of data or analysis of data and an epidemiological approach to health equity as a priority for the Office of Public Health. In that vein, over the summer, actually back in the spring, the Office of Public Health partnered with the Office of Drug and Alcohol within Health and Human Services to apply for new funding for opioid prevention. For several years, we've had funding from the Department of Health, the Pennsylvania Department of Health, for overdose data to action work. That work was funded through the CDC to the Pennsylvania Department of Health. And the Pennsylvania Department of Health then sub-granted some of those funds to local jurisdictions. Montgomery County was one of those. So we had a relatively, compared to what we're receiving now, a relatively small amount of funding, a little under $200,000 for that work. In the spring, we applied for a new stream of funding that the CDC developed specifically for local jurisdictions. So the funding stream changed. They created one stream specifically for states and one stream specifically for local jurisdictions. We submitted a proposal together with ODA, Office of Drug and Alcohol, and we were awarded about a little under $900,000 per year over the next 5 years. May I ask you, advance? So this really allows us to build substantially on that work that had been achieved through the initial overdose stage to action grant. Previously, Montgomery County through OPH and ODA convened an opioid fatality review team to really take a close look back at opioid fatalities and understand gaps, or identify and understand gaps in the system that could have prevented or could prevent future fatal overdose. We'll continue to do that work, and we'll expand it to add more. Can I ask you to continue? So as I mentioned, it's just under $900,000 per year for 5 years. It began on September 1st. The funding will be shared across the Office of Public Health, the Office of Drug and Alcohol, and a network of providers. The University of Pittsburgh will provide evaluation support throughout the duration of the process. And there are 5 major strategies associated with this program.
Is that their public health school?
It is their public health school. And the University of Pittsburgh was the evaluator for the Pennsylvania Department of Health grant as well, so we've asked them to continue with us for continuity. They're also providing evaluation support to the other grantees in Pennsylvania. So in addition to Montgomery County, the Philadelphia Department of Public Health, Allegheny County, and the Pennsylvania Department of Health were also all awarded additional OD2A funds. So we've already started to talk with one another to understand what each other is working on and where the areas of overlap are, so that we can collaborate and work together and learn from one another in this process.
So I don't mean to interrupt you, but is then is the UP, the University of Pittsburgh Public Health School going to be sort of the coordinator for that for all of you? Make sure everything that's shared?
Actually, the Pennsylvania Department of Health is coordinating all of that, coordinating those calls for us. So we actually had a first call on Friday to talk through just the overarching priorities that each of us has included in our grant. And then we've identified some specific areas where there's overlap and where I think a smaller group of us will continue. So the epidemiologists will meet on a regular basis, and then we'll have some strategy specific areas for us to talk on a regular basis. But from our conversations with the University of Pittsburgh, they are all also talking with one another.
Yeah, given the number of Medicaid lives that are under their auspices, and they, I would think, would have some interesting information. That's great.
So the 5 major strategies associated with this funding source are linkages to care. And what we'll be focusing on is increasing and supporting a network of navigators throughout the county. We have not yet identified specifically where all of those navigators will be placed. But we have identified that the Montgomery County will be hiring a certified recovery specialist to work in partnership with our correctional facility to support individuals who are leaving the correctional facility. We've also identified one potential partner to provide a navigator within an emergency department setting. So in the first 6 months of this process, we'll be doing a community needs, actually it's first 9 months of this process, we'll be doing a community needs assessment to help us understand where the opportunities and gaps are, particularly from a navigation perspective. What we're aiming to do with those navigators, and this is one of the priorities for overdose state of action, is to help individuals connect with care and remain in care. Okay. As the second major strategy associated with this work is distribution of harm reduction kits and training around naloxone administration, CPR, and again, and those harm reduction kits include things like naloxone, additive test strips, and other supports for individuals who are actively using, but making sure that those are getting into geographies and to communities where they are most needed. A third strategy associated with this funding stream is stigma reduction. Through this, we are planning to conduct an awareness campaign, provide training, and particularly provide training on engaging with individuals with substance use disorder, right? Really shifting how those interactions with representatives of different systems happen. Again, to support connecting individuals with care and staying in care. So when I say stigma reduction and training around engaging with individuals who have substance use disorder, we're talking about public safety, we're talking about healthcare, we're talking about community-based organizations, individuals within systems that may come into contact with folks who are living with substance use disorder. Clinician and healthcare systems best practices. This allows us to provide some support for training and academic detailing for healthcare providers and health systems that would like to expand the use or implement navigators, harm reduction, or stigma reduction, or other clinical best practices, again, for supporting individuals who are living with substance use disorder. This will be largely informed by that community needs assessment that we do early on in this process, right? So that we can understand where the needs and interests are for our clinical providers. The last, oh, go ahead.
I was just thinking, anybody else can, please feel free to ask questions, you kind of stood, so the community needs assessment should identify if housing is an issue for these folks.
It could identify the primary focus of the community needs assessment is directly to inform how we operationalize these strategies, right? So we have an overarching plan for the next 5 years, but the specifics or the details on how we direct the investment from the CDC will be informed and guided by that community needs assessment.
Okay. Anybody else have questions?
Yeah, I have a couple of questions. You had mentioned somewhere along the line DEI. My question is, the state of DEI in the last few years, currently in our department, and what's the plan moving forward?
Yep.
That's one question.
Okay.
The second question is, I'd like to know, you're brought up, like University of Pittsburgh, they probably have an idea about surrounding counties because they also contracted, you said. Not sure like how we are in relation to surrounding counties or other areas, the top tier or what.
With respect to opioid use, do you mean?
Many of these things.
So in terms of opioid use and in particular fatal overdose, Montgomery County has experienced a decline in the number of fatal overdoses over the past few years, sort of up and then down. In terms of the surveillance that we are doing through a DPS, a Department of Public Safety created system focused on overdose surveillance. I'll say that what we're able to achieve or what we're able to identify through that is really focused on Montgomery County. While our fatal overdose burden or numbers may be on the decline or maybe lower compared with other counties, the systems that we have developed here in Montgomery County really support that, right? Really would help us achieve that decline in fatal overdose. So what we're doing through this grant is building on those systems. And I'll say what one of the reviewers for this grant actually noted was that while our burden of fatal overdose is lower, the systems that we've created, the systems that we've established here, are so strong that's part of what's directing the investment, that we're able to build on those systems. In terms of DEI policies and procedures, Toy will actually address a little bit of that in her update a little bit later. So I don't want to steal her thunder. So I'll let her address that in a little bit. But for overdose data to action, this is also specifically focused on those inequities and those disparities, mimicking the rest of the Commonwealth and the rest of the nation. What we're seeing is disparities in fatal overdose burden, particularly impacting people who are Black. So when Pottstown and Norristown is where we see the highest rates of overdose and fatal overdose. And then within that, when we look a little bit deeper into those geographies and across the county, what we see is an increase in overdose and fatal overdose among people who are Black, while it's either remaining level or changing just a little bit among people who are white. So this work is actually specifically focused on addressing those gaps and those disparities, using that surveillance and really targeting the interventions to where they're needed most. Does that answer your question?
Yeah. Thank you.
So to that point, in addressing all of these strategies, that first year really is infrastructure building for us. As I mentioned, that the grant that we've had up to this point was about $200,000. This is a pretty significant expansion and investment. So we're taking that time and that step back to do that community needs assessment to understand where the gaps and the opportunities are, where the needs are, again, specifically to address those inequities. And then we're also convening a community advisory board that will help to guide and inform much of the work, particularly focused on the stigma reduction and harm reduction work. individuals on that community advisory board will represent some of the folks, some of the organizations that are within our care network, but more specifically, it will include people with lived experience to provide that perspective. Can I ask you for the next slide?
Just a quick question on that. Where do the harm reduction kits, where do they physically go?
Where are they distributed?
Yeah,
They can be distributed in any number of places. What we would look for, what we do look for is sort of geographic hotspots and locations where
I mean,
see higher
community services or doctor's offices or.
community services, doctor's offices, could be hotels and motels.
That's like, yeah.
Right? What we're seeing increasingly is the use of like vending machines. It's not something that you pay for, but it's actually a machine that can be placed in like a train station, for example, or another place where our data is showing us that there's a particular hotspot. So our colleagues in Allegheny, Delaware County, Philadelphia, and I think it might also be Chester County or York, are actively installing vending machines, and that's something that we might want to look at for this opportunity.
Thanks, Stephen. The question is, and maybe I'm interpreting it incorrectly, but I get the impression that the drug overdose aspect of this far outweighs any other aspect. So in other words, is this something where most of the 889,000 is heavily focused toward the drug stuff, or are we also expected to include some other things within this grant?
It's focused on overdose prevention, in particular fatal overdose prevention.
Okay, so for over the next 5 years, that's okay. Gotcha.
You got it.
But
That includes-
I'll also add, and I don't know if you're gonna get to this during other parts of the meeting, so there's a lot of, ideas being raised and questions around, things like DEI or disparities or housing or other social determinants of health, which are clearly important. And although they may not be directly addressed in this OD2A grant because of the focus of it, please know that for the Office of Public Health, we are also planning to address that in other ways. We have been talking about the importance of creating a health equity profile for the county, which will tap into things like disparities or social determinants of health and how we're faring in those areas. And then have also talked about, just in terms of our people resources, who can sort of lead those efforts, and really talking about bringing someone on board who can help us from a health equity and population health perspective. So not part of OD2A, but part of other things that we'll be focusing on in the years ahead.
For this particular grant, there are a few positions that are directly supported by this work. First would be a coordinator for the program that will be responsible for the overarching operations. That position will actually be located with the Office of Drug and Alcohol. So again, this is part of this partnership between the Office of Public Health and the Office of Drug and Alcohol. While the funding is coming through the CDC to the Office of Public Health, some of the staffing that's associated with this will be located or structurally located with the Office of Drug and Alcohol, along with one, possibly two certified recovery specialists. And again, that network of providers that will be supported. So those certified recovery specialists may not all reside with the county. Some are likely to reside with provider organizations that are already based in community, have relationships in our communities that we're serving. In addition to that, we have part of our epidemiology team that will be associated with this, as well as the health equity director that I mentioned earlier. I believe that that's it for this particular presentation. Really just wanted to give you a high level overview and introduce this to you all. This is something that we'll certainly share back with you how this is working over the next 5 years. But in particular, we would likely be asking for some of your support in terms of the community needs assessment, gaining perspective from all of you. And insofar as a lot of this work will be done in partnership with health and healthcare, we'll certainly value your perspective, your support with bringing some of this work to life. That's great.
I would just encourage us also to look at how this, because there's, IBC, for example, has got a lot of work going on right now with respect to health equity, and almost all the providers, I think, at this point are participating. So how maybe it can integrate with not just IBC, but the other insurers, I think is going to be critical too. especially all of those providing Medicaid.
And I wonder if there's other health departments that are a little bit ahead of us who have done work in health equity, and if we could, learn from that, what they've learned, and then apply it here. Yeah, thank you.
Good point. Other comments?
Yeah, but it's been, I did ask you early on, not sure how much of a partnership we have, for example, in school districts and medical organizations, and the medical society. And we can access to a lot of the physicians, not sure.
In terms of our work with the school districts, the Office of Drug and Alcohol has, on Office of Public Health certainly, but also the Office of Drug and Alcohol has ongoing work with some of the schools and school districts around opioid prevention, around drug use prevention, and mental health overall. In terms of our relationship with the Medical Society is actually one of the active partners for this grant. So they provided a letter of support. They work with us on the opioid fatality review team. And they are in a position to support us with some of that work around training, education, and information that can be shared out with healthcare professionals. So they've been an active partner with us. We're really grateful for that partnership.
I will also say we've had some outreach just in terms of collaborators, whether it's school district or managed care organizations and things like that. We have had some outreach and some discussions with major healthcare systems in Montgomery County who are interested in fostering more public-private partnerships. Also have conversations planned with Health Partners, their chief medical officer there. And you're correct, it's not just other managed care organizations, but perhaps other counties or other states. The importance of developing a health equity profile is really critical. And I think also underlying that is the importance of data. So that's going to be a significant focus, not just for Office of Public Health, but for HHS as a department.
Thank you. Moving on, Denise?
Good morning. Everybody's been waiting to hear about our budget.
Yeah.
We're gonna just talk through highlights of our expenses and our revenue. So, Twigga, can you just forward 2 slides? Okay, the first slide is our budget summary. Just looking at 2023 and 2024. Our 2024 budget reflects an $8.3 million reduction in expenses and a slight increase. It's a $687,000 increase in revenue. Our 2023 forecast reflects a $10.3 million difference in revenue. And on this slide, it shows a $1.8 million difference in expenses. However, that forecast was a little overstated and falls more in line with our 2024 projected or proposed number. Next slide. This slide shows our grant revenue by project and or funding. It primarily will show you that we have level funding across our programs. There are slight increases annually that have to do with the subsequently available funds and or carryover. One of the things that this will show you, if you look down further at the table, we have additional funding that we did not have in 2023 that we have in 2024. We have new funding, hospital fire detection grant, public health infrastructure grant, and the lead ARPA grant. Next slide. This slide shows you our fees, our 2023 and 2024, as well as 23 forecasts. Basically, our fees are level. I mean, our fees slightly change from year to year based on various factors, water quality. Fees have to do with the market, real estate, construction. So again, those fees slightly vary from year to year, but primarily are level. Same goes for the environmental field service fees.
again, our E&Ds, we have approximately 400 establishments, licensed facilities from year to year. That's pretty stable. So again, those fees across the board look the same from year to year.
Is there any increase?
We do increase our fees 2% annually.
So very nominal.
Yep.
So it's a, okay.
Okay, this slide shows you our expenses by funding and or project. And again, this just is to show the slight variations from year to year with the numbers between the projects. I just want to point out in this slide, the other block is where we have all of our salaries and fringes. Salaries and fringes for budget purposes are budgeted not at the project level. The next slide, please. Again, this is just another comparison to show the difference is this does not include salaries and fringes. And then next slide, please. This slide, just to give everybody a little breakdown of each of our funding streams and the percentage of funding by students. There, question.
Didn't know I was gonna do that, but, so is there any, and obviously good presentation, you know, we've obviously had reviews of this and had the opportunity to ask you and the team a lot of questions. Anything from your perspective that gives you concern?
So I think the biggest concern for us right now, which is skewing the numbers, is our COVID ELC funding. That funding came to us, it was approximately 40 million. That money took a long time to get executed. We did use a lot of that money initially. We looked to carry some of that money over to rebudget that money. We still are waiting for that allocation. So again, the COVID services have diminished and are barely happening now. So our costs are minor, and we just don't know what that picture looks like. So that, again, from a budget perspective, it kind of throws our numbers off, not knowing based on what we had in our allocations versus what we would potentially have in the future.
And I mean, I know there's a lot to go into that, and it doesn't just affect, I think, the health department. So is there a time frame on when, you know, we should have an understanding of that and the implications? And if it's no,
We
that's
keep asking the state.
okay.
We do check in with them regularly. We
Understand.
have not gotten an answer.
I understand. And there's a lot of complexity. I totally understand that as well. Okay. They're working on it.
So I have a question. If I look at this sheet, well, so we looked at salary and wages, it's flat. And I'm just wondering if there is, for one, how we're doing on workforce and positions, but also is there any increases that would be expected that are not included yet? Do they come at a different time?
So that initial, I think that was part of the budget packet, Barbara, that you're looking at. Initially, when we submit the budget, we do not submit anything for salaries and fringes. So that's why that sheet is flat. This has the increased salaries and fringes in it.
So there would be an increase?
Yes,
Okay.
correct. Yeah.
So
and
that
then
came out of the human
Right.
resources, as it always
the
does.
the result of the comp study, the increases are in here. What we do not have is potential salary increases for the new year We
Oh, we
know.
don't.
No.
But we would
Right.
anticipate there would be salary
Correct.
increases? Yeah.
Yes, yeah,
I
and
mean, I
we'll
think
get
there
that
should be-
after the official budget's adopted.
Okay. And
January.
any percentage that you normally project?
I believe it's 4% is the proposed increase this year.
That's good. Great, thank you.
Appreciate it. Other,
Couple of questions. How our salaries are they competitive to attract the best people for the jobs? And I thought different things. And the question is, some of us are the steering committee for the new commissioners. Not sure whether there's some information that we should be telling them. Do we generally get what we want from the commissioners, not sure.
I'll
Well,
let Christina.
What I would suggest, and I understand where you're coming from, I think we need to let the teams and the new leadership sort of work on this for a while and then come back, and I'm pretty comfortable that they're gonna do the right thing. And they understand the issues as well, so I don't mean to speak for them, but I think it's probably a little bit too early, you know, in the process. So you wanna add to that?
I think that was a good response, perfect. To Denise's point, the county did recently conduct a compensation study to look at competitiveness. I would say that, you know, I'm hopeful that some of the adjustments that have occurred will be helpful to us from a recruitment and a retention standpoint. That's historically been a real challenge for us. But I don't think that I don't think that we're terribly different from other government or local government entities in that regard.
And I would just add that I don't think you're any different than anybody that's in basically anything related to the healthcare space and other spaces, you know, throughout not just this region, throughout the country at this point.
So a technical question on contracted services, you're going from 13 million in 23 to 4 million.
And that's due to the COVID ELC money.
It's just not receiving it. I mean, you're not budgeting for it at all.
So we budgeted a little bit for it. We just don't know what it looks like and what that plan on spending is.
Is it up to 9 million? Is that the difference, or you just have no idea?
So we should really, our allocation should be around 11 million. But again, it hasn't been confirmed from the state.
Okay.
We don't have that contract.
It's a big number. It's a big number in the budget.
But is it
Yeah.
something like the pre-pandemic?
Correct.
Is right,
Correct.
more or less.
Right,
yeah.
Yes,
Like
it's
that.
all, yeah.
What pre-pandemic?
Is
Right.
that paying back for services already rendered? And is there any possibility of them not sending it because you're not using it now?
So, as far as the COVID ELC fund, so, yeah, so our pandemic budget, our pandemic level budget was substantially higher because of, COVID funds. The current ELC funds, from the Pennsylvania Department of Health, we're able to access those funds confirmed through June of 2024. The likelihood of needing them is relatively low.
Right.
But we have that incorporated into the budget, because it's a confirmed revenue source. The expenses that are associated with that may be limited to to none, in the coming year. One of the aspects of the communication with the state about that specific funding source and one other COVID funding source is the potential for an extension beyond 2024. So that is not yet confirmed.
But is the opposite also a possibility that they can say, with the pandemic, you don't need it?
It's certainly possible. So we, earlier this year, we had some conversation with the Department of Health, and the DEC really wanted to understand, well, of the funds that have been made available, what is likely to be in use? So some of that funding has actually already been liquidated. But we retained some of it so that we're prepared in the event of, a change or something that's unexpected.
Got it. Okay. Thank you.
Any other? Go ahead.
And I'm sorry, just to your point, yes, that funding is reimbursement based, so it's not funding that's sitting with us. It's funding that can be drawn down and utilized in the event that it's needed.
Got it.
Any other questions, good discussion, good presentation as always. So we need a motion to accept. Second. Any other questions? All in favor, please say aye.
Aye.
It's unanimous. Thank you very much. Appreciate that. Okay, moving on to the priorities. Okay, you're gonna go first, huh? What's your? Dave's gonna go first, okay? Morning. Good to see you.
Okay. Then stop sharing. Stop sharing and share.
Okay.
Jimmy, you wanna just go on while I try to figure this out? What?
It's showing on here, but.
It's on Facebook or not?
Yeah.
Okay, so we kind of a connection.
Okay, so I'll just start. Good morning.
Morning.
So I want to start with, and the focus is going to share about the workforce assessment and the other public health communications and stakeholder participations. I want to kind of touch up on some of the reviews and updates of training and professional development for our divisions. So there are two areas that we focused on, and we are continuing to go through this process. One of which is to review division specific professional training. So for example, for DIS, this is intervention specialist. What type of training are we not providing? Are there other certifications can we give them? So we're looking into those type of avenues. For SEOs or sewage enforcement officers, they go through some statewide training, but there are other water-based training. So for example, I believe we added a well water training to the agenda. And for environmental health specialists, for their training for our food safety component, we implemented the FDA retail standard training this year. So that will be implemented to the continuation of onboarding training for them. So those type of areas we're looking into for FEP, specific planners trainings. So for example, medical countermeasures, and also for general planners. So we're looking into those avenues to make sure that we have specific trainings that are going to allow them to succeed in their positions. The other area is the general public health training. So for example, public health communications. We're looking into cultural competencies, social determinants of health and health equities. Those are pretty much public health 101. We want to make sure that we include it in our training for our staff. And lastly, we started to update the standard operating procedures for all of our divisions. So basically, it's to get a good cadence of reviewing of the SOPs to make sure that they're up to date, one, and to make sure that we follow the most up to date procedures and policies. And that also affects our deliverables as well. So those are the areas that we're working on. And before I go on, any questions on that? Because now I want to kind of ask our division directors to kind of go through their 2023 priorities that they I want them to share a little bit about that and give you guys an update.
Thanks. Questions? Yeah, it's good.
Okay, good. Okay. So with that, I'm sorry, there should be a PowerPoint here, but let's start with clinicals. If you can, do you need help?
Our first priority for 2023 was to resume clinic operations fully. And so I'm happy to report that we are in Willowbrook, not Willowbrook, in Norristown, and Pottstown. We have our immunization clinics, as well as our STD/HIV testing and treatment clinics, as well as a TB clinic that we hold every week in Norristown. Things have changed, which was an opportunity after the pandemic to modify our structure. And one of the things we did was to tease out the tuberculosis clinic and make it just TB patients, both active and latent TB infected individuals. Before we used to combine our community disease clinics. So now we have separate clinics, and it really is, I think, efficient. It's working well to do that. And we always have an eye for, what do we need? Sometimes we see, for instance, tuberculosis patients in Pottstown, but right now we have our clinic efficiently in Norristown. So we are back up and running with those 3 clinics at those 2 health centers. Our numbers are lower. We are seeing more walk-ins as the year has gone by. A lot of throughout historically, we've had a lot of walk-ins attend our STD HIV clinics. And so I think the word is slowly getting out. We're doing some advertising with social media, but the word on the street, we are seeing an increase in walk-ins. So we think our numbers will continue to increase.
About Willow Grove, renovations are still a long way off. The design, I understand, is going to be, for our clinic there and other offices out in the Willow Grove Annex will be happening in 2024. And then, you know, commence with the building. So it's going to be a while till we have services back. Our next, yes.
Do you have a question?
I do, but I was gonna wait.
Okay, keep going.
Our next priority was to fully implement the EMR, fully implement. Are you ever done? But we have made progress in implementing, for instance, our mass vaccination module that we used during our community vaccine campaign. So people could make appointments onto our Patagonia electronic record. We have a reminder recall we got up and running, but there's still, you know, work to do. So we're, you know, blow by blow, program by program, making modifications. So fully implement, that'll be on the 2024 priority too, to continue to fully operationalize on EMR. And last but not least, our priority, and we're joined at the hip with this one with PEP. Is to build a collaborative community vaccination program. And I want to say it's been wildly successful. You know, I'm speaking really for Megan, so chime in here because she leads the meetings that we have, both internal meetings within our own staff or clinical, you know, our PEP staff, but also our medical reserve corps is part of these meetings, as well as pharmacy partners. So those are our external partners that we meet regularly with. And it has been really exciting. I think we are unique in Pennsylvania in really having a public-private partnership, so that the goal being that we can serve anybody who comes to us during our mass vax campaigns, uninsured and uninsured, so that the pharmacy partners can build the insurance. We have funding sources for vaccines for people that don't have insurance. But also we have been very successful in going into community organizations, so hard to reach groups, where smaller, you know, churches, different organizations, schools, you know, people come through. I did mention our other partner, MCIC, Montgomery County Immunization Coalition, really creating a great repository of getting requests and getting partners out there, you know, pharmacy partners, as well as our own staff, medical reserve corps, to meet the needs, to get to the people who feel comfortable, wherever that is, whatever organization, that we can actually offer vaccine in those venues. So I've stolen Megan's thunder with that too, because we really have been joined together with that.
With regard to Willow Grove Clinic, was this prolonged downtime anticipated, or was there some other reason why it happened? And if it wasn't anticipated, is there anything that can be done about that?
My understanding is that the county has considered the Willow Grove Annex for several years as to whether it was going to look for a different facility or renovate this. So it has been a long time coming, but then the commitment now, I understand, is that they are going to stick with that facility. Yes, and it's, you know, with anything, I think things with pandemic, I think postponed a lot of the plans, I believe, but yes, I don't know that there's anything to speed it up. But that is my understanding that it's coming.
Do you have a timeline on, like, is it coming in 24?
So in 24, I understand the design will be done and maybe some groundbreaking, but they thought the renovations would continue until 2026. I'm hoping that they prioritize the clinic aspect so that we can have clinic space accomplished first, but there's other people and agencies in the building, so I don't know, you know, what the priority will be, but you know.
The county owned that building?
Yes.
I mean, can we get temporary space from somebody else? Because, I mean, to not have a clinic there for 3 years or more, I forget how long it's been closed already. So, I mean, that's a really long time. And I wonder if there's some other space that we could, you know, that people would give us gratis in order to have it.
Yeah, we'll have to look, you know, we have been kind of waiting to hear what the timeline was. We expected it to be more already in place.
That's
But it keeps
I
getting.
would, and I think some of us probably have connections in that region, okay? When other colleagues that, you know, and when we're not competitors when it comes to basically figuring out how to get access to clinic space. We had to talk about that. I think that's where you're going, both of you. are going.
Yeah, I think so. And then I just have a question about your staffing. How are you doing with your nurse staffing and are you in a good spot?
Yes, well, we have, because we aren't offering services in Willowbrook, that kind of takes a little bit of the sting out of our short staff. We are still down by, I believe it's 5 full-time nurse positions. But we had a couple of full nurses. We just hired another full-time nurse. So we are holding our own. We're able to staff the clinics that we have and the services we're offering. But when we open Willowbrook, right, that is, you know, where we can.
So what's that vacancy rate? Is that,
I would say that's third, right? Let me check there.
so better than the 50%?
Yes.
But still challenging.
Yeah.
I do have to compliment, you know, your department for doing the collaboration. I think that Till did an outstanding job. I believe she had almost like 80 different organizations, all ethnic groups, all kinds of people. The pandemic was bad, but I think it did help to bring multiple groups together.
Anything else? Let's go to Michelle for communicable.
So my priorities for 2023 for our division was to apply lessons from COVID, really in the work that we do. I think this is going to be ongoing. It's going to take time to really look at the impact of COVID and what we need to improve upon. But this year we did do a couple of things that really did help us in the roles that we play. Leverage of technology. I think this is something that we are really embracing. So this year we got access to HSX, or what's that, healthcare exchange. And this allows us to get quicker information from providers around treatment. It also allows us for continuum of care to really look at somebody's history and allow them to continue through that care. So that's been a huge plus for us as we do our investigations. We've also started to investigate text message systems for monitoring individuals, as well as for things like syphilis, where we're in a shortage of bicillin, and individuals need to take antibiotics for a long period of time, up to 28 days, doing reminders to make sure that those individuals complete the treatment so we don't have additional disease spread. We've created an online form for food complaints. So that individuals don't have to call our office or really can submit any complaint related to foodborne illness through our website. We also, similar to what Ruth and FEP is doing, is collaboration to help coordinate that collaboration and networking is, and working with our healthcare providers on a care continuum. So not working as a silo. So if individuals need treatment for syphilis, instead of them necessarily coming to our clinic, you know, redistributing medication to their medical home where they're comfortable to really facilitate healthcare and the care that they're receiving. We've also worked on health literacy and getting information out there, how people want to receive it, the way they want to receive it, taking time to reach multiple populations. And then access to services. We introduced at-home STD HIV testing that can be requested online. So individuals that aren't able to come into our clinic or to other businesses or areas that don't have free services, they could order a test kit online, that test at home, and we collaborate to do notification and treatment. And then, like I said, similar to syphilis, it's redistribution of medication. So not sort of having to come to us, but giving services to people where they are and where they need it. Another priority was the development of a multi-drug resistant organism response plan. So in 2023, we did receive direct funding from PADOH to be able to hire someone to focus on this program area. We have a staff member who's working to get certified in infection control and prevention. And then we've been working directly with the state to develop policies and procedures around the response. We've also seen an increase in this area. We've responded to almost 35 plus investigations of multi-drug resistant organisms where we need to provide infection control recommendations, do prevalence screenings, infection control assessments. So there's been a huge learning curve, but making small steps to really develop that program.
Question, Michelle, I'm not sure whether it comes under your area. As you know, the Jefferson System Abington Hospital abruptly closed the children's clinic in Banksdale. I used to be the volunteer medical director for years and years before I retired. We were all taken by surprise. Nobody knew. I'm not sure even if they ran it by the health department. Not exactly sure. Not sure, Mike, like what our role in, we were seeing like 20, 30 children, every single day. About the time I left, it was about 3 years back, probably about 60, 70% of the children were Hispanic. Probably about 20% were Asian Americans, and then the rest. And then, I did call the Jefferson System, explaining my frustration about these children, either the very bad insurance or no insurance, very bad transportation. And Brian Sweeney, who is the president, one of the regional presidents of the system, did all kinds of excuses, but without any good, because I'm not quite sure whether you have any comments on that, or Christina, I'm not sure what your thoughts are.
I've been in touch with the VNA Community Services a little bit prior to and following the closure to understand what the fallout from that is. I know they've absorbed some clients. I know that I believe that Jefferson also had a transition plan with an additional provider to connect patients from that clinic with the additional provider. Off the top of my head, the name isn't coming to mind, but I believe that the VNA Community Services certainly has been monitoring what the additional caseload has been since the change that happened by the new provider.
Other thoughts on that? I think we can always go back and have conversations. And at least from my perspective, the Jefferson folks are very involved in population health, and committed, to population health, and they're one of the largest providers in the region for the Medicaid, population. So I've got to believe that they would clearly be open to looking at how to do that, but also integrating everybody into private practices too, with different models, because we're talking to them about that as well. So let's figure out how we can work together. I understand your concern. Anytime something closes, that's a concern. Thanks for bringing that up.
I'm going to do a quick time check here. We are running
Yes.
quite a bit behind schedule. I know we had a little bit of a delay getting connected with technical difficulties, but I'll ask for the remainder of the updates. If we can keep those to your most salient update that you'd like to share. And for our final presentations, if we can keep those relatively brief. Certainly the slide decks will be shared outward following the meeting, but just to make sure we can keep everyone on time.
I appreciate that. So we should try to figure out how we get done about 10, maybe 15 minutes later. Yeah. Okay.
Okay, I'll be quick.
That's
So,
okay.
the priority for our Environmental Field Services Division was to upgrade our digital health department system, which is what we use to conduct all of our inspections. So it's what the staff uses, and it houses all our data for inspections. So we are working with Tyler Technologies to upgrade that system. We started working with them in the spring. It was supposed to go live in December. We're now pushing go live to April. And that will also then give us the capability of accepting online payments for our facilities. So so we're moving forward with that. We're
Perfect.
still working it.
Thank you. Thanks.
Yes.
Megan?
So our biggest thing, is we are reviewing and updating the existing plans using after action reports. The biggest part of that is, Preparedness has, entered a contract with Constant Associates, where we will completely overhaul the medical countermeasures program. So the biggest thing to come out of that will be a newly revamped mass distribution system, Much like we saw with the COVID-19 response, mass vaccination response, and our community-based testing. The hope is we're taking a lot of the lessons learned from that response, incorporating it into how we're going to do things in the future. So the contractor has started doing some small group interviews to get some really focused feedback. A survey is in its final iterations and hopefully will be out within the next week or so. And then in January, the contractor will be on site for several days to do large community focused groups, looking at their draft recommendations around the new medical countermeasures program. The other big part of that project, which I am very excited about, will be a revised pandemic plan. But it will incorporate more than just pandemic influenza. So it will cover high consequence infectious disease for pathogens for which we know a lot about: Ebola, anthrax, smallpox, and then pathogens for which we don't have a lot of medical intelligence around, such as we saw with COVID. So how do we respond to things that I think, as Ruth likes to say, we build the plane while we're flying it and responding to it. So it will be a comprehensive response plan around multiple pathogens. So that will take a good portion of the first half of 2024 as well for us. And then my team will take it from there once the contractor's time ends with us. And, you know, we'll continue to build it and improve it and hopefully never have to use it.
Yeah, questions? Sounds great. In light of the news in the world and the FBI director coming out yesterday and saying the likelihood of terrorist attacks in our country has just skyrocketed, are we focusing on that at all as a immediate priority? I mean, 6 months from now is a long time in that world.
Yeah, so we are looking at, we monitor those threats every day. Thankfully, we do have a standing plan around bioterror agents, anthrax and smallpox specifically. We know if we had to stand it up tomorrow, if we had to stand an MCM program up tomorrow to respond to something like an unfortunate terrorist event, we could do it. We've done it. I think COVID proved that it might be a little clunky in the first couple days, but we can do it and we can sustain it if we have to. The hope is with this project, those first couple days would be a little less clunky.
And I can add to that also, although we need to have our own robust system for that, there are other resources within the Commonwealth of Pennsylvania that are specifically directed to that.
Thanks.
David?
Yeah. Good morning, everybody. So we used most of 2023 to close out our Safe and Healthy Communities grant, which ended September 30th. Over the last several months, my team has been involved with restructuring our programs and services. We want to base our programming decisions on collecting and analyzing a wide range of information to help direct our resources to where they're most needed and where they're going to provide the most impact. With that being said, we'll continue to focus on reducing and preventing chronic disease by providing access to healthy foods, access to safe physical activity, as well as unintentional injury prevention. We're also continuing our community traffic safety program or project through our PennDOT grant. Programs that we plan on continuing from 2023 into 2024 include providing ongoing nutrition education lessons to students in grades 5 through 8 at Eisenhower Middle School. In addition, we'll continue partnering with Eisenhower Middle School to maintain a 40 raised bed community garden. The only difference is we're moving from a county-driven garden to more of a community-based driven garden. We'll continue providing CPR and AED classes, including naloxone administration for Montgomery County residents. We will, in partnership with school districts, to continue providing education to students about traffic safety, pedestrian safety, as well as bicycle safety. Also in partnership with the county and community organizations, we'll continue to maintain the Montgomery County Trail Challenge as it promotes safe walking and biking opportunities.
Questions? Okay, last,
Yes, right, I'll be quick. In addition to Pam, or like Pam, we're going to upgrade our digital health department for water quality, the water quality database as well. I just wanted to say that it does have this capability, GIS capability. It has civic access capability, so people can conduct online payments. And it also has the capability of residents submitting online complaints. So it's a really good program. So we're in the process of the validation testing now. And again, hopefully we'll be live in April, but who knows, it's been pushed back several months already. So there's that one, and then develop and implement a wastewater surveillance program, and I'll talk about that in a few minutes. Sounds good.
Okay, we'll go right into talking just a bit about our workforce development assessment and our community health assessment. Just give a couple of updates on that. In the interest of time, we're not going to do a whole lot with our community health assessment. I would like to point out, Dr. J. Raj, that as we move forward in assessing operations internally and externally, we are building our DEI muscle within our office. Our leaders are taking cultural competency and cultural training. So we're using that health equity lens as a foundation for what we're doing moving forward. Okay.
If I might add, we hired an organization called MGT of America to actually come in and do an assessment of policies and procedures across all of health and human services, or an assessment of policies and procedures that either support or serve as sort of a barrier to advance our DEI goals and objectives for the county or for health and human services. So they worked with us to review things like HR policies or other procedures within our operations and help us to identify priorities for action going forward. We provide a little bit of a deeper dive on that.
I just want to share the project timeline for our community health assessment and where we are right now. As you can see, we are working with our steering committee. We've convened a steering committee of community members and organizations, and we met twice already. We're looking at our focus areas and looking at ways that we can engage with our community. Our steering committee is helping us in that journey to make sure that we are connecting with all members of our community. Like I said, we established that 15-member steering committee. They're helping us identify the prioritized focus areas. They're providing guidance on community engagement strategies, and they're providing insight, expertise about communities in which we live, work, learn, play, and pray. Our next steps include to finalize our community participation targets, engagement strategies, develop a survey that we will distribute to the community, develop and conduct focus groups in our community health assessment, analyze the results, share the findings, and then launch the community health improvement plan. The plan is a community plan, it's our plan. So we will continue to collaborate with our community with our health assessment as well as this community health improvement plan. We're also conducting a workforce assessment. It's a workforce capacity and training needs assessment. That would include an assessment of our staff arrangement, our skills, the staff skills, the competencies as it relates to characteristics and needs, our standard core competencies as public health professionals. We brought in a consultant to do this work with us. We have established a workforce development team, an internal team to work with the consultant. The workforce assessment will lead us to develop and implement a capacity development and training plan. And part of the accreditation standards and requirements is repeated every 5 years. So on our road to accreditation, we're doing these assessments to make sure we are filling the gaps. What's included in that plan, the workforce assessment, we're looking at external considerations such as community health and needs, peer practices and policies, what other counties are doing in our area, accreditation standards, and the public health competencies for our staff. Internal considerations include surveys and focus group, and I said the consultant will come in and help us with that. And current practices and policies that affect OPH, such as training opportunities. How will we use this information? The consultants will prepare recommendations for workforce capacity and training. And by the end of it, we should have 3 deliverables. We should have an organizational capacity assessment and recommendations. We should have workforce development and training needs assessment based on their recommendation, and workforce development and training plan. So we're in the gathering phase right now, and I'll share with you the project timeline. We're in the gathering phase of getting those documents to the consultants. We met with the consultants once, and our team is meeting with them monthly. They're gonna conduct the capacity assessment, and by the winter, we'll have an assessment of our competencies, our internal competencies with our staff, and they'll make recommendations on what we need to do moving forward. And I finally like to share, and we're so grateful that we're gonna have a new public health communications manager coming on, Teresa Harris. She works in our county communications department. She's very familiar with Office of Public Health, a lot of county operations. She was instrumental in helping us through communication for the height of COVID. Teresa's worked with several of our divisions. So we're very excited that Teresa's coming on, and she starts on Monday. And some of her priorities will include helping us with a communications plan for our community health assessment. She's going to be helping us to establish networks and partnerships, and she already has a lot of connections working with the county communications. And I know she also works on the DEI committee and the Racial Equity Action Plan committee. So she's very involved in that sphere already. So we're glad that she's bringing that with her to work with us. As far as the risk response communications, she's going to be looking at health advisories and how we disseminate health advisories, who's in that network of dissemination, how we should do, and plan for when we have wastewater surveillance, and Kyle will share more about what we're doing in that area. She's going to help develop those communication plans across all divisions. Questions?
Thank you. Any questions?
If I can just make one comment, direct to you. It is very fashionable today, across all levels of the country to have a DEI officer. It's almost like it seems like a mark. But statistics also show that they do not accomplish much. Probably internal resistance, all kinds of things. So my view on that is as a small department, we have to set a target. So we've got to say, and it cannot be done quickly, it should not be done quickly. It's also not right. Maybe 10 years, 20 years, and you got to say that Montgomery County must reflect the population at large. So that's my hope, if I can suggest.
I appreciate that, and I have to say that Donna Richmond is the chief DEI officer for Montgomery County, and as an individual, she holds responsibility for quite a bit across the county, and it's not her responsibility alone to ensure that the county meets its objectives in terms of advancing diversity, equity, and inclusion. It is the work of all of us. So it's not the responsibility of one person in any organization. It's certainly not the responsibility of the county. It is all of our work to ensure that we are part of the process, and we're all working together towards making sure that we are implementing the plan that we create.
Thank you. I'd also like to say, Dr. J. Raj, I'm reminded of this sport. It's a marathon. It's not a sprint when we're dealing with this. And being a part of a lot of those conversations, Donna has actually brought in speakers to talk about what they've done over the years. And I think it was Fairfax County. They started in the eighties. And just recently, in the last 5 years, 5 to 7 years, they've really gotten things moving. So I think we're realistic in the expectation here and that we're gonna continue.
Good to hear. Thank you, Glenn. Any other updates or we can, no, I think we've done a great job, a lot going on, a lot to sort of, for us to comprehend. So we appreciate it very much.
And I think that's why we wanted to give you an update on how things have been going this past year. All of the work that you've heard described here is in movement towards that accreditation goal that we described earlier this year. So this team has been really remarkable in moving quickly, whether it's updating how folks can pay their fees or their licensing requests, or just changing some of our internal and external policies and working with our community to do that.
Two things, who are we getting accredited by and what positive things happen after that?
Absolutely. So the Public Health Accreditation Board is the entity that confers accreditation to health departments, whether it's state, local, or tribal.
Is that federal, government, state?
None of the above.
Okay.
It's an external agency, or not extra, it's a
Non-governmental, got it.
Agency, and they provide the accreditation standards and measures. They work with a number of agencies to really define what those standards and measures are for health departments across the country. But essentially those standards and measures are sort of like the middle benchmark. It's not the minimum, it's not the maximum, but it's what every health department should be able to demonstrate in terms of meeting or providing essential public health services. It's a long process for that accreditation. For us, it'll probably be somewhere between 2 and 3 years, because it requires things like the community health assessment, requires the workforce assessment, and not just the assessments, but also the actual plans to address what's been identified there.
And once we get that, are we eligible for grants that we're not eligible for now, things like that?
Having talked with folks that have gone through this process, and it's a tedious process, but they have found a couple of benefits that really stood out to me. One is a really centralized sort of purpose and understanding and sort of coalescing around the work that the health department does, and a sense of sort of morale, right? Because we are demonstrating in this process that we meet these standards, right? Or that we exceed these standards. So there's an element of pride that comes with that, but beyond that, they have said that they feel like they've been able to receive funding that they may not have otherwise been able to because they achieved accreditation. There's an assumption there that the health department is meeting its standards. So even when you're applying for federal funds, when you can show that you're accredited, there's an assumption there. Okay, this organization meets all of these standards.
And it's ongoing.
It's ongoing. It is ongoing every 5 years.
Great. Good discussion, good question. So, Dr. Lorraine.
Just gonna do the quick time check. It's 10:25.
So good morning, everyone.
And thank you, Dr. Lorraine.
Okay. Could see, I was gonna say, I'm going to do a quick recap of the ACIP meeting, and I'm gonna make it even quicker.
Okay.
So I'll see if I can kind of rival that old FedEx talker commercial. See if I can get it done. But what I'm gonna do is basically just highlight the important things. So ACIP, for those who may not be familiar with it, is the Advisory Committee on Immunization Practices. That is the arm of the CDC that provides recommendations on how and when to use various immunizations and vaccines. It's come under particular scrutiny over the last 4 years, mostly in regard to the ongoing process with COVID vaccines. That's an important step before we are able to implement those immunizations. So they had a meeting at the end of October, and they discussed a number of topics, voted on 3 different areas. And some of them are fairly relevant for what's going on right now. Some of them are just really setting things up for the future. So this is the list of items that were on the agenda for that time. I'm not going to go through it. Next slide, please. So this is one of the important ones that was voted on, meningococcal vaccine. To this point, basically, we've had meningococcal A vaccine, actually 4 different serotypes, and there's a meningococcal B vaccine. And for the first time, we now have a pentavalent vaccine, which is the A, it's actually ACWY, and there's the B vaccine, and now it's all included in a single pentavalent vaccine. So this was approved a little while ago, it's Pfizer's vaccine. The advisory committee was looking at how we're going to implement it. And basically the answer ended up being that we're going to be putting that in place of the first meningitis vaccine for those mostly kids who are indicated to get both the ACWY and the B vaccine. Next slide, please. So those were the items that they voted on. There's a very strong consensus that it should be included for those who are supposed to get both of those vaccines, that it need not be included for those for whom only one of the vaccines was indicated. If there's only a recommendation to get that first vaccine, those should also not get it. So you'll see that a little bit later on when we look at the recommended immunization chart for pediatrics. Next slide. These are the things that they're going to be looking at going forward. We can skip that. Mpox vaccine, this was another thing that was voted on. So up to this point, we've had essentially just emergency use of Mpox vaccine because of the outbreak that we were experiencing. So this is the first time that they actually came up with a recommendation for how the vaccine should be used officially. It's not very different from what we've been doing to this point. So there's both post-exposure treatment, there's pre-exposure prophylaxis, and the most important thing is it's based on risk factors. This is mostly a sexually transmitted disease. So there's a list down at the bottom there of risk factors for the vaccine, and now the ACIP voted to officially recommend that as part of their policy. Next, please. It says a couple, yeah. So these are the different recommendations they came up with. Just keep looking at that. Okay. One concern is the potential for myopericarditis. That's inflammation of the heart muscle and the lining around the outside of the heart. And the reason why this is a concern is that a similar vaccine, is actually the smallpox vaccine, the ACAM, has that as a known potential side effect. This has not been seen to this point with the Mpox vaccine, but it's a very similar vaccine. So that's a concern ongoing as to whether or not we need to be aware of that as a potential side effect. Next, please. And this is their schedule for what they're going to be doing going forward. Next. RSV vaccine has been a big topic lately because we've had our first RSV vaccines approved. There have been already recommendations for it. This is a kind of codification and discussion on those recommendations for the RSV vaccine. Notably, right now, the 2 RSV vaccines that are currently licensed are approved for adults only. There's a pediatric vaccine that's being worked on, but not yet approved. There is a monoclonal antibody that has been approved for children, particularly infants under 8 months or older children who are at increased risk for RSV infection. As an aside, we're seeing a fair amount of RSV right now, not as much as last year, but still a very significant amount. And this particular monoclonal antibody is in very short supply. So that's making it somewhat problematic in terms of treatment. Next, please. So one of the important things that the ACIP is looking at going forward is the recommendation for adult vaccination. So the recommendation is 60 and older. But they're going to move that down, at least look at the population from 55 to 59. And there's some important aspects of that we'll see on the next slide. So when you look at the burden of illness in adults 50 to 59, there are some disparities there. There's some equity issues basically here. So you will find that hospitalization rates in the 50 to 59-year-old range for RSV are higher among Black, American Indian, and Alaska Natives than they are for other groups. So that's the thing that the committee is going to be looking at going forward as to whether or not they should extend that recommendation downward to age 50, and if so, should it be for specific groups? Next, please. And that's what that part talks about. Next, please. Flu vaccine. So they reviewed all that we're doing with flu vaccine right now. The recommendations have not changed with one specific exception. for the last 5 years or so, there's been a knowledge that egg allergy is not a contraindication to flu vaccination. Concern earlier was that since most flu vaccines, and up to about 5 years ago, all flu vaccines are made in egg culture, there was a concern for people who had egg allergy that they should not get flu vaccine. Aside to that is that, honestly, from clinical practice, when I've talked to people who claim egg allergy, they don't have egg allergy. They may have an intolerance to eggs, but it's not a true allergy. So for the last 5 years, we really know that there's so small an amount of egg albumin that's left in these vaccines that it is of no consequence, even if it is a true egg allergy. Now that's been known in the medical community, but they've still been kind of following the practice that they won't give flu vaccines to people with egg allergy, with the exception of the 2 that are now prepared without the use of egg culture. So the official update with that for this meeting was, and we'll see that later on in the adult vaccine recommendations, is there is no longer any contraindication with egg allergy, period. So any of the flu vaccines can be given to people with egg allergy. The other thing that they looked at going forward is the constitution of the vaccine. Every spring, there's a projection as to what strains are going to be prevalent in the following flu season, and that's what's used to develop that year's flu vaccine. It's either 3 or 4 strains, depending upon the vaccine that's used. For the last 8 years or so, there's been a B strain, Yamamoto strain, which basically they were looking at it saying, you know what, we're not even seeing this anymore. So they, excuse me, Yamagata, not Yamamoto. Yamagata vaccine strain. So they looked at that and said, we're not seeing that at all anymore. We're going to recommend going forward that not even be put into the vaccine. Next, please. All right, so this was the third thing that the ACIP voted on, which is their recommendations for routine pediatric and adult immunization. So these are the updates that came through. There's a lot of them. The ones in red are the ones that have at least some significant action associated with them. I will go through it really, really quickly. So COVID vaccine, we no longer have the bivalent vaccine. We're using the updated 2024 version, and that's both for pediatric and adult. I mentioned the issue with influenza vaccine, no eggs, and no egg allergy issue anymore. Meningococcal using the pentavalent vaccine, where both vaccines are indicated. Polio, they changed the catch-up recommendations. RSV antibody, I talked about how that can be used. Monoclonal antibody for the at-risk children and the shortage of that. And important thing with the RSV vaccine, although it's not licensed for pediatrics, it is strongly recommended to be given in pregnancy, so that will afford some protection for the child once it's born. Next, please. So this is the standard thing that comes from CDC every year. Your question.
But that was the only one of the 2 strains, right? In other words, the only one is approved in pregnancy, the other one is pregnancy. On the RSV, it was
the RSV vaccines. Yes, yeah. One vaccine, but the Abrysvo is approved for pregnant women, and the Arexvy is not. So only one vaccine. Yeah. Thank you. So that's a recommended immunization schedule for pediatrics. And that's it in graphic form. The updates for adults, COVID, pretty much the same thing. Influenza, I mentioned. Meningococcal, same thing. Mpox is now a specific recommendation for individuals at risk based on at-risk behaviors. Polio is it identified people potentially at risk, even if they have gotten the full series, might get a booster. I pretty much mentioned the RSV also. Next, please. There's the things that come from CDC that tell us how to use it.
This is all going to be posted online.
Yes, great.
Yeah, okay, good. Yeah. Chikungunya vaccine. So did we, oh, good, the update made it on there. So at the time of the meeting, they were expecting an approval of the vaccine, which has been done as of November 10th. There are general recommendations for the use of the vaccine based on potential for exposure. Chikungunya is a mosquito-borne virus. It's typically endemic in Africa and Asia. The last case in the United States was seen in 2016. So this is mostly, from our perspective, from travel. And there's the recommendations next. Just a brief note, these are recommendations that come out from the SAGE organization, which is part of the World Health Organization. That's their equivalent of ACIP. I wrote down what that meant here. Strategic Advisory Group of Experts is what SAGE is. So I like they call themselves experts. Dengue vaccine. Oh, yeah, okay. So dengue vaccine, this is kind of interesting. There was a vaccine that Takeda was working on. They've actually withdrawn their application several times. They're still updating it. The ACIP has kind of tabled their discussion on it until the vaccine is represented. This also is a mosquito-borne virus disease. It's typically peri-equatorial, but we do see it in many territories of the United States. Interestingly enough, we actually do see it in the continental United States too. There have been a few cases recently in the area. One of the states that has the highest level of cases is actually New York. So it can be seen in the area. So at the moment, there is no vaccine that is available for it. Takeda is working on exports. COVID vaccine. So
is that transferred from people that were someplace and then somehow these mosquitoes ended up here?
no, it cannot be transferred from human to human.
No, I know mosquitoes that came
Likely.
in vegetables and fruit, whatever, right? Okay.
COVID vaccine, I mentioned that, and everyone's pretty well aware at this point that bivalent vaccines no longer being used. There's an updated single valent vaccine that's been used for 2020. It's defined as the 2024 vaccine. It is derived from one of the Omicron subvariants. And that's just the guideline, the timeline in terms of when that was approved. So this is something I just want to highlight a little bit. About not quite a year ago, there was some signaling in the monitoring program for COVID vaccine safety that indicated an increase in non-ischemic stroke for non-thrombotic or non-vascular stroke, not non-hemorrhagic. Sorry, I was blocking the term for a minute. So there was an increase in non-hemorrhagic stroke in older people, 65 and older. We're getting both the bivalent COVID vaccine and the flu vaccine together. So this is something that popped up as a signal, not anything that was necessarily associated or causing. So it's been studied since then. There's actually been about 23 different studies looking at this. And to this point, there has been no direct association found between the use of both of these vaccines and an increase in non-hemorrhagic stroke. So the important takeaway from this is that this signaling, this monitoring is very, very useful. It's working very, very well. It's very, very sensitive. And it pulls up information that we might take action on later, depending on further study. So this is just a kind of an early warning system. It's the canary in the coal mine, if you might say. And it just indicated that there could potentially be an issue that needs to be looked at more closely. Once we looked at it more closely, there was found no specific association and certainly no causation. As an aside, of course, we're no longer using that bivalent vaccine. Next, please. There's a number of pneumococcal vaccines that are in development. There's been a slight change in terms of the recommendations for pediatrics, a 20-valent vaccine in place of a 13-valent vaccine. The idea of pneumococcal vaccines is that they help to prevent the more common forms of pneumonia. It's not all pneumonia, it's pneumonia specifically caused by Streptococcus pneumoniae. And there are many, many different types of this. So they're looking at decreasing the number of strains within the vaccine. Next, please. And that's what's going forward in terms of the most developed vaccine that's likely to come out soon. Next, please. So I'll take a deep breath. And I will take any questions if there are any. Just a little advertisement on there for tomorrow night's Ask the Experts. I will be monitoring that along with 3 of our distinguished medical colleagues in the area. We're focusing on influenza vaccine, as this is National Influenza Vaccination.
Yeah, so this is tremendously helpful, and I think you did an excellent job summarizing it. The one thing I would say is I think that flu vaccine, which we've required for, I don't know, 15 years, we've seen an increase sort of like, I don't want to get the flu vaccine, which was fascinating. And I think that even though the egg allergy thing is going to be a non-issue, I think getting people to accept that is not going to be easily overcome. And so I wouldn't expect people to say, oh, now I can get it. I think that'll be a long-standing, myth that will carry on, and we won't be able to get away from it, is what I think.
I think you're absolutely correct. And we've actually seen that because the last few years, there has been that information out there, but it hasn't even been adopted across the medical community. So that's certainly going to persist. And there is a little bit of an increase in reference to flu vaccination this year compared to previous years. Part of it, we're kind of thinking, is that the vaccination fatigue, if we can use that term, that we're experiencing given the COVID vaccine over the last few years.
Yeah.
I can say as an aside, I was dealing with exactly that issue this past weekend on the military side, where the flu vaccination is mandatory, and we definitely saw an increased resistance.
Yeah, fascinating, right? Yeah, us too.
Other comments or questions? Just watching time too. I really appreciate that. Great. And I know that, obviously the health department is a resource to the members of the community that have, questions about this. So I'd encourage, that to be utilized. So, Kyle.
Okay, very good.
So we're going brief, right? Kyle?
Okay, I'm going brief.
I promise on this to you so many times.
It's okay, but I'm a W water. It's in the end of the alphabet. It's okay. I got it. I'll be quick. It's about 16, 17 slides, but I'll cut it down to 5 minutes. Here it goes. Okay, get this out. Quickly, what is wastewater surveillance? It's wastewater, I'll read this to be quick. Wastewater-based epidemiology, or WBE, and wastewater surveillance, WS, use samples from raw, untreated wastewater, which is influent wastewater, not treated, to estimate pathogen infection prevalence or trends within a designated sewer shed or facility. So it's a sewer shed, it's the catchment area, it's the collection lines that all run to a particular sewage treatment plant. Or it could be a facility like buildings, a building complex, like a university or long-term care facility. This is key, positive sewage sample analysis results can show a disease trend before an observed increase in clinical disease trend, often days in advance or even a week in advance, kind of like the canary in the coal mine. Next, Toyka, please.
Let's keep going.
Oh, okay, very good. So wastewater surveillance, it can determine positive results from residents with symptomatic and asymptomatic individuals. And then once the health agencies are aware of this, they can act. And I'll explain how in a little bit. Bottom line is, it's an early warning system. So there's a graphic at the bottom of the second slide that just basically you collect the samples, you analyze them, you interpret the significance of the data. We talk about what the intervention might be, and the interventions could be something like public messaging, targeted clinical testing, or even increased vaccination efforts. That's for any wastewater surveillance. History of wastewater surveillance, quickly, it's been done in the past mainly for polio and cholera. But now that was in the past. Now it's considered a core surveillance method along with clinical surveillance. And it's because I just thought it was fast, it's efficient, it's effective. and it's early. It's an early detection, so that's good. CDC has a program, they developed it in September of 2020 during the pandemic called the National Wastewater Surveillance System. It's a great website if you want to get on it, to take a look at it. A lot of the information I got is from there. And then the Department of Health for Pennsylvania followed suit, and they have the PAWS, Pennsylvania PAWSS, PAWS, Wastewater Surveillance System. So background of wastewater surveillance in the county, I won't go into it. We didn't have anything, of course, but during the pandemic, a lot of people were calling me, environmental scientists, township officials, they wanted a program. And I said, don't have the money. Lo and behold, ARPA funding became available. ARPA, American Rescue Plan Act, had some money available for projects for COVID. I said, oh boy, let's go. We submitted a proposal on Janet Panic and I proposed it back in 2022, and they accepted it in June of 2022 as a project for ARPA funding. Now we do use workforce development grant funding first, but then we're gonna use that ARPA funding. So I won't go into these details, but we had an RFP review and process because why this is a little over our head, both the workload and the expertise. You know, the seven of us in water quality, it's a little over our head to be able to pull this off. So we felt a consultant's a perfect public-private partnership. We'd get involved with a consultant that could help us pull this off. We put out a request for proposal. BioBot was selected. BioBot Analytics, they're out of Cambridge, Massachusetts. I won't go into their CV there, but they are very qualified. They have a lot of experience. They formed in 2017, and they've been doing a lot of this wastewater sampling around the country, and even in Pennsylvania. They've also been hired by CDC and DOH at the time, but they're no longer DOH. But anyway, very good company, and we're pleased with them so far. So yes, so skip that. It's the yes, we went through that already. Okay, very good. The wastewater sampling site. So I had to pick out sites where to sample. We wanted it to be geographically representative, but also large scale sewage treatment plants. There's about 20 or so in the county. I picked 4 and then 2 other facilities. And I'll go into just quickly, we'd be sampling from wet wells. I'll get that in a second from these other 2. But the 4 treatment plants, they're in the west, in the middle, and on the east. They're already sampled by wastewater treatment plant staff. They sample continuously all the time anyway. All they had to do is split a sample with us. BioBot provided them all the materials that they need. And I never did go into that. BioBot, what do? They sample or collect samples. They analyze the samples. They provide the equipment and supplies. They provide interpretation of the results, and they upload the results to a dashboard that only a few people, few of us have access to. So they wanted sampling sites. We selected them, and I took a little bit to get to them, a little coaxing, cajoling, but for the most part, everybody came on board, and they've been very cooperative. Now, the 2 sites that didn't have wastewater treatment plant staff sampling it, we had to set up a subcontractor to set up what they call auto samplers, composite samples. This is a machine with a hose and a little port device that sucks up the sewage, and every 15 minutes, 96 aliquots in a day, 24-hour periods to get a representative sample throughout a 24-hour period. So we do this now, and I'll get into next the program planning with BioBot. BioBot was hired in December. In January, we talked with them. It's develop a plan. I won't go into all those details, but we met several times. We talked with the wastewater treatment plant staff, and again, that subcontractor was hired. We began sampling. So we talked in January, and the program was implemented and started in February of 2023. Here, the wastewater sampling flow. So we have 6 sites, 4 wastewater treatment plants, 2 pump stations. Those pump stations, again, use those auto samplers. The SARS-CoV-2, and we sample for SARS-CoV-2, again, because that's the ARPA requirements that we sample, it has to do with COVID. So we sample for the SARS-CoV-2. We also do variant sequencing. So that's really interesting as well. Right now, for those that care, EG.5 and HV.1 are the two variants. The rest of it, shoot, I forget, the older, the Omicron and all those subvariants off of it are all kind of old hat. Now it's these two variants are dominating the scene right now. EG, again, 0.5 and HV.1.
So this is amazing.
Sure.
I love this stuff. So, but are we basically testing for other things too, other than?
Gotta get to that.
Because
Next
I'm
slide.
sitting here thinking in the next slide, right, but I'm sitting here thinking, we should spend the time on this maybe at the next meeting where we really do, keep going, where we truly understand this, and then how's this information, I know you'll get to this, really gonna be used, and I have lots of questions.
Pretty good.
So,
Okay, I can do it again.
Yeah.
If you'd like.
Well, I know, I think it's just, I mean, to me, this is great surveillance information. It's how are we gonna use this to basically improve the health of the people that we're taking for?
Get to that, right?
Yes, okay. So the program implementation is up and running. We are working on a response plan. It's the last thing that we need to do, a public response plan. That's what you're probably talking about. With the main thing is that we want to notify those when we have an elevated level of significant increase. This is determined by our ERAs, or Epidemiology Research Associates, and the State Department of Health. If there's a significant trend, not a little bump, but a significant trend that the public needs to be notified. Public awareness is crucial here. Who's for COVID, it's 50+ age are the people that need to be notified. And that's so we have public health partners, hospitals, long-term care facilities, senior centers, even legislative offices will be notified when an increase is such that of significance. So we're working on that response plan right now. And the messaging will include COVID mitigation strategies. So we will send them to our website to talk about the strategies. So here's the future for the program, and I think you were going to talk about this. After this response plan is complete, we want to talk about maybe other pathogens such as the respiratory package, influenza, and RSV. We're thinking about that. In fact, we even put a budget request in for those pathogens. Or do we go into sampling for high-risk substances? Cocaine, fentanyl, methamphetamines, another good thing that we could do. The funding issues for ARPA, though, are very specific for COVID-19, and so we have to only do that as of right now. The money's finished. Here's the future, and here's an issue. The money's finished in December of 2025, we're estimating. So at that point, do we continue with the program, or do we go into these other pathogens? Again, it's a money issue. I hate to be blunt about it, but that's the key thing. And then also, I'd like to get eventually a new environmental health coordinator to oversee this program, among other programs, like maybe something for climate change or something for indoor air quality or whatever. But that's something I'd like to look for in the future. A couple of quick slides. That's what the dashboard looks like. Oh, click it, please. Thank you. That's what the dashboard looks like. Those peaks were one particular facility there that were really high and were significant, and we addressed that facility specifically. Next, we got these are real quick. That's the sewage treatment plant. Everybody's seen them. They all drive by them real fast in summertime because they smell so bad. So there's a pump station, also called a wet well. We set up the auto sampler, which is the next slide, please. That's an auto sampler. It's about 30 to 40 pounds, 3 feet high, 2 feet in diameter. That's the one that sucks up the sewage into the container. Again, the 96 aliquots every 15 minutes per day. So, again, questions? That's it. That's all I have. Is that quick enough?
I mean, I love the fact that we're doing this on COVID, but I guess I see all kinds of opportunity.
Yes.
To basically, clinicians here would know better than me to identify things as they're trending and see if we can't do preventative measures, not just for COVID, but all kinds of.
Agreed.
I think this is exciting, and that you've got this off the ground is fantastic. So
Thank you.
I just would like to not stop it, obviously. Let's see how we can maximize the.
And hats off to Kyle and to everyone that's working on bringing this to life. The ARPA and the COVID specific funds have enabled us to build the infrastructure, bring this to life. And part of the process really is understanding and establishing baselines for viral levels, in each of the jurisdictions, right? And then developing and implementing the response plan. So wastewater surveillance, data shouldn't be looked at on its own. Similarly, clinical data it's helpful to use this data together, right? So it takes a little bit of time to understand the baselines and then to sort of work that alongside the clinical data, hospitalizations or other information that's available to us to understand what's normal, right? And what constitutes a sort of a break in an unusual pattern that would then prompt a notification of some kind. So the next step is our team has mapped the geographies around the sites that are being tested and what higher risk institutions are within those geographies so that notification can then go out to inform, we've seen an uptick in COVID. You might want to consider some, mitigation strategies that are right for your population. So that's that next step in this, and to your point, the other pathogens that can be tested, that's a future development or a future potential for us.
Again, we've talked a lot about doing things from a data-driven standpoint. I see this as sort of one of those key elements going forward. And I think a lot of times, again, we're not using data and making assumptions. And I think it seems like that's the whole direction that you're going with all of these different initiatives. So I applaud you. Any other, go ahead.
Oh, just one last point I wanted to make, and I'm just the mouthpiece for the group. We developed a wastewater surveillance team. It's Jay, it's Dr. Lorraine, it's Michelle Masters from Communicable Disease, and our two epidemiology research associates. So there's 6 of us that actually do this. I'm just the talker for the
I
group.
totally understand it's a team, but it does take different, like all of you, different people to lead. So I think all of you take leadership in all of the different areas you're passionate about. And in my opinion, it's come through to all of us today, so we really appreciate it.
Thanks, and also kudos to Toyka.
Oh, I was saying,
And kudos to Toyka. Her scoop is in the poop is wish I was my joke and it's not. So thank you. So, and I'll use it again if we ever have to. So.
Okay, with that, I think with that, that's the perfect way to end this. Anybody else have any business they'd like to bring before the board today? Again, before I move from adjournment, I just would like to again express my gratitude to everybody on behalf of the board. Also wish everybody just a joyous, peaceful, and healthy holiday season. Lots of stress going on in our communities and the country and in the world. So I just wish everybody, some time for peace and joy. So move for adjournment.
Adjourned. I got motion.
Second.
All in favor?
Aye.
Thank you.